Cambia Grove, for those of you that might not know us just yet, is an innovation hub, a health innovation hub. We aim to see that innovation flows more freely in healthcare. We wanted to see a healthcare system that is more patient-centered and financially sustainable for all. We do that in 3 ways. We convene. We gather in rooms like this to get the community together, to bring together the collective expertise of this community to better understand the bright spots. Where is innovation most needed? We also are a co-working space. We're a free co-working space. In this room, we're open 9 to 5, Monday through Friday. Think of this as your office. Come, hang out, grab a cup of coffee, have a meeting. If you're a health innovator, you're in. We have meeting space in the back too. You can reserve that. This is your office. We convene the community in events and in our co-working space. Through that convening, we identify those bright spots, as I mentioned. That's the second thing we do. We identify those bright spots. And when we identify those, we then catalyze solutions to lower barriers so that innovation can flow more freely.
Another show of hands. How many people were here on during our first 5 Points of Healthcare conference back in 2018? All right, there were a couple of you. Now, what was so interesting about our first 5 Points of Healthcare conference, there was a couple of things, really. First, we did it a little differently. We had each segment of the 5 Points of Healthcare have their own day. We started out with an overview, which was very real, very awkward at times, and really it gave us a lot of insight into really what was happening in the healthcare system. That first one gave us so many learnings. I'll tell a little story. So 5 Points of Healthcare was something that we developed back in 2017 here at Cambia Grove as we thought through what it meant to be a healthcare innovation hub. First thing was, let's define healthcare. What exactly does that mean? And we started out with the patient and thought, well, of course, the patient has to be in the center and everything revolve around the healthcare system. And so then we started ticking off, okay, so who else is involved? Well, the provider. And the payer has to be involved as well, or excuse me, the payer is involved as well. We have purchasers and we have policymakers. And policymakers have a big part, especially as regulations continue and the debate continues. So we have all of these different stakeholders. Now, how was the system designed to work? And then how does it actually work? And those were the first 2 questions that we sought to answer during our 2018 5 Points of Healthcare conference. We commissioned a graphic recording artist in 2018, just like we have commissioned a graphic recording artist for our 3rd annual 5 Points of Healthcare conference. And over here with the Doodle Biz will be joining us throughout the conference to document what is said. But what was so interesting with our first 5 Points of Healthcare conference was when we asked those 2 questions, how is it designed to work and how does it actually work? What we ended up getting were literally 5 distinct silos. Lots of white space. You can see the silos themselves in that graphic recording over here on this wall where we've got so much information on the top and in the below, but you'll see a lot of white space. So how do we, one of the things that we want to do now is how do we look at those white spaces and try and work together as an entire healthcare system, including entrepreneurs, community organizations, the rest of the 5 points. How do we work together to understand the inner workings of the entire healthcare system? So these are the goals for this conference. Understanding the inner workings of the entire healthcare system. How do we connect all of you innovators in the room? We're all innovators within the healthcare system looking to change. Innovators can be within the 5 points. They can be entrepreneurs. Innovation means that we're all trying to seek change. So how do we connect innovators trying to work on these problems? And then how do we coalesce around high priority topics? We've got a lot of brain power in this room. We have a lot of people in this room who can make incredible, impactful changes. So 2 rules for this conference, and these are 2 rules that we try to stick to within the 4 walls of Cambia Grove. One is to ask questions. always ask questions. There is going to be a question. 99% sure that in your head throughout this conference, there will be a question in the back of your head, and you're going to say, oh, I just don't, we all do this. Oh, I just missed something. Or, oh, I just need to figure this out. No, ask that question. Use poll everywhere to ask that question, because if those questions are not answered, then they're not answered, and we need to answer those questions. So ask that question. Teresa, who will be on our purchaser panel, she and I were just catching up, and one of the things that I loved in our quick catch-up was this idea that you need to know enough to be dangerous, but not enough to have every single answer. So need to know enough to be dangerous, but be an open mind. There are going to be some questions asked that you're going to say, oh, I've already heard that question. But there might be some insight within whoever answers that question. Second rule, have fun. Absolutely, have fun. This will be a fun, sometimes awkward, sometimes real conference. That's what we strive for here at the Cambia Grove. And so please enjoy yourself. We are thrilled that you are staying here for a day and a half, and we're looking forward to having fun and getting a lot of good work done. So, with that, we are going to move on to our first panel discussion, first discussion. And our first discussion, it is my honor to have Dr. Bill Weeks come on up and join me on stage to discuss a number of different things. But Bill is with Microsoft Healthcare Next and is a principal researcher there, and has agreed to join us to kind of give a big lay of the land from a number of different angles. So please join me in welcoming Bill. All right, Bill, go ahead and let's take a couple minutes and please discuss what you've been up to over the last couple of years, who you are and what you've been up to.
Sure. So I'm the father of 6. That's kind of the key thing that I am. But prior to coming to Microsoft about 1 year ago, I spent 30 years at Dartmouth as a health services researcher. By training, I'm an addiction psychiatrist and an economist. And there at Dartmouth, I did health services research, kind of studying geographic variation and quality and value in healthcare for that time period. At Microsoft Healthcare Next, I'm continuing some of that work and trying to maybe leverage some of the thoughts that we had in a book that's available back there for you all that Jim Weinstein and I wrote that are kind of pain points from a patient perspective as they go through the healthcare journey, and thinking about how technological solutions might kind of relieve some of those pain points.
Fantastic. Okay, so in the next about 12 minutes or so, I'm looking at Julie, who's going to be my timekeeper, a little bit under 12 minutes. We're going to try and go through 3 large questions. Those include, why does the U.S. relative to peer countries pay the most and kind of get the least, if you will? Is change possible, and why are big tech and other players getting involved? And then at the end of this conversation, we'll have some time for audience Q&A. Also, feel free to use poll everywhere. So, Bill, why does the U.S. relative to peer countries pay the most for healthcare and have the worst outcomes?
So that's a fabulous question, and I'll get my Nobel Prize on the way out, I think. But so I think there are 3 main reasons, right? First is prices that we pay. Uwe Reinhardt and Gerard Anderson wrote an article in 2003 in Health Affairs that was called "It's the Price is Stupid." And then after Uwe Reinhardt died, Gerard Anderson did a reprise of that in 2019 that said, "It's still the price is stupid." We pay too much for the stuff that we get. That's number 1. Number 2, we get too much of the wrong stuff, right? We pay too much for stuff we get, and we get the wrong stuff. The challenge is there's an incredible amount of waste in the healthcare system. We overuse certain things. Some people have underuse, but we spend 30% of the healthcare dollar on wasteful things. And that's that's waste. It doesn't contribute to outcomes. In 2003, Elliot Fisher at Dartmouth wrote a great article that kind of demonstrated that of the three buckets of healthcare that Dartmouth Atlas has defined, effective care, which is stuff that we know works, right? So beta blockers after heart attack, this works. And 40 years after figuring that out, we're running at about 85% or 9% of the population getting that, not 100%. Some stuff works. There's preference-sensitive care where you can have multiple different options for treatment for the same condition. So if you have knee osteoarthritis, you can get PT and Motrin and stuff like that, or you can get knee replacements. Those are two reasonable options. From Dartmouth, we're kind of agnostic. That should be up to patients which one of those they choose to get based on what their anticipated outcomes are. And the third thing is supply-sensitive care. This is where the more hospital beds you have in a community, the more physicians you have in a community per capita, the more you spend, the more you use, right? So when Elliot looked at costs of care, what the costs were buying, what higher spending was buying, it wasn't buying more effective care. When you look across different geographic regions, 306 HRRs in the country, hospital referral regions in the country, it's not buying more effective care, it's not buying more preference-sensitive care, what's buying is more supply-sensitive care. So more visits, more optional care, more x-rays, stuff like that. And the irony is that the additional costs that are embedded in the consumption of that care actually were associated with greater mortality. So you're getting less stuff that we know works, less stuff that might be reasonable for people to have choices on, more stuff that is really questionable as to whether it works. And that pursuit of more stuff that's questionable doesn't actually contribute to health. It actually contributes to the opposite of health.
So what you're saying is this supply-demand, or demand-supply.
So supply or induced demand, right, which is where me as a physician, it's a fascinating thing. So as a physician, I can bring you back when I tell you to come back, right? Mm-hmm. And in a market that has a lot of physicians per capita, but my game plan as a physician is to keep my schedule booked, right? If I don't want to have downtime. I want to be busy and continue because I have operating costs. I'm trying to make a profit here. So if there's a lot of competition in the area, I might see you 4 times a year for something. If there's not, and I have a bigger patient panel, I might see you once a year. And the interesting thing is for something like controlled hypertension, if you're in Sweden, you might be told, you got controlled hypertension. Come back when you have a healthcare problem, right? Don't come back whenever. We don't need to schedule you again. So the outcomes are probably a little worse with the repeat visits because we tinker. And when you tinker in a system that's kind of stable, it doesn't necessarily do. It can kind of throw it out of stability. So the sense is that additional supply kind of creates its own demand, which accelerates healthcare costs. And these are persistent, and they can actually be kind of cultural. So for the last 30 years since we've been studying this at Dartmouth, Miami has had the highest per capita healthcare costs from a fee-for-service perspective in the nation, and they've consistently been the highest. And Fort Collins, Colorado, has consistently been the lowest. And this is after adjusting for health status and age and sex and stuff like that. It's persistently cultural that they have a higher supply, they use more services, and it's really unclear whether those services do any good. In fact, they probably don't.
So this is great because I see a lot of...
I have 3 points.
Oh, excuse me. I thought I got... Okay.
The third one, yes. That's all right. The third one is that that we invest... we invest in a sickness system, right? Not a health system, right? And when you look at Elizabeth Bradley's work, which compares the combination of healthcare and social resources as percentage of GDP, U.S. is kind of in the middle of OECD countries, right? We just spend the vast majority of that in healthcare. And as everyone's finding out, and everyone's now investing and really excited about, social determinants are like 80% of health, right? So healthcare makes a marginal contribution to health, but primarily in part because it's a sickness. So we're treating diabetes after you already got diabetes. We need to not have diabetes. I think the kind of the best metric for healthcare in the U.S. is who doesn't need to use healthcare. That is what we should be shooting for as a key metric. So in social investments, like in every other OECD country, address things like housing insecurity, food insecurity, job insecurity, things like that, that we know really matters when it comes to health. And so those are the three kind of broad reasons, I think, why we're underperforming.
So Bill and I have gotten a chance to get to know each other, and each time I talk to Bill, I come up with way more questions. And so I knew this was going to happen in terms of us having this conversation. And as you've outlined your three, my next question is, what you said it's bad to tinker in healthcare. Is it a tinker that we need in the healthcare system to reverse these trends, or is it something bigger? And that kind of goes to, is change possible, and how does this change reverse the trends that you've seen in these studies?
Well, I think you have to have hope, right? I mean, they have one of my favorite books is Count of Monte Cristo, and Edmond Dante's last words are hope and wait, right? That's what we need to do. And we're getting impatient with the waiting part, so we should just hope more, I guess. But I think there are things we can do, and to me it's around incentives, right? Alignment of incentives. Right now we have this fee-for-service model where the incentive is to make more widgets, do more stuff, and even as I said, my incentive as a provider is to fill my schedule so I can do more stuff, because short of that I can't generate enough to pay myself or my staff and stuff like that. So if we realign the incentives by relatively simple things, but incredibly hard to do, like capitating, right? So once we capitate a population, what used to be profit centers become cost centers, and suddenly we are much less interested in doing more of that stuff. We kind of want to do less. And the challenge is, of course, making sure it's quality. We want to do the appropriate amount. But we're starting from a point where we're probably doing 30% too much. So there's areas and ways to go down there. So I think alignment of incentives is kind of critical, and CMS and CMMI are trying to do that. ACOs are trying to do that. It's just I think it's such an incremental way that it's not you get kind of this partial shared savings kind of thing that was started at Dartmouth. Elliot Fisher kind of thought up the idea. And it's movement in the right direction. The bundled payments is movement in the right direction, but my concern there is that thresholds for patients then change. So if I'm getting paid a bundle for a knee replacement, I suddenly don't want to see people who are sick, who might put me at risk for spending more than my bundle. And I might see a lot of people who don't quite really need a knee replacement yet because they're easy, and I guarantee they'll have a great outcome. You remember, I think it was Tenet, I hope no one from Tenet is here, in Redding, California, there were some cardiac surgeons who had fabulous outcomes from their cardiac surgery, mostly because they operate on people who didn't need cardiac surgery. And they were making tons and tons of money and doing really well, but we have to really watch about how the incentives you create can have unintended consequences, so we have to monitor that, I think, quite a bit.
Okay, so that awkward feeling that we're all trying to get?
Yeah,
that's good. So we've got a couple more minutes for me to ask questions, and then we've got a couple minutes for the audience to ask questions. So think of your questions, should you have them. And I'm going to ask one more question from here, and that is, so you've talked about some incremental changes, especially around the alignment of incentives. Big tech, you're at Microsoft. What's going on with tech, and why do they want in for healthcare?
Yeah, so I personally, and this was before I came to Microsoft, actually, I think tech has a lot of potential solutions to some of the pain points that we have. So if we think about social determinants of health and monitoring people, right now, if we think about, someone who's really pretty sick and uses the healthcare system a lot, say they spend 2 weeks in an inpatient setting and they spend 2 additional whole weeks getting outpatient care that we capture through little notes in the EHR, we're capturing like 10% of their life, right? There's a 90% of their life that we're missing, right? This kind of thing here, and questionnaires that say, are you food insecure? Right now, if I want to know food insecurity, I can get it at a county level from 3 years ago. That doesn't really tell me if you're food insecure or you are. And my sense is that what happens is people will, they'll go along, they'll be doing okay, and then there's a shock. There's an economic shock. They're job insecure, they're food insecure, something happens, and we need to capture that, because that's the signal for future healthcare consumption, where there's an opportunity to intervene. Trying to apply stuff at a very high level, we need very granular data, and tech can do that for us. It's doing it kind of now. And I think tech can help with efficiencies. Tech can help, identify fraud quickly when it happens. Tech can help in so many different arenas across all these. Really, kind of bring together your 5 Ps for communication and learning and improvement and value creation.
That's great. Questions from the audience. We've got 2 mic runners. All right, Susie. Here's a mic right here.
Hi, Susie Dade with the Washington Health Alliance. I've been in this business a long time. And I hear 2 things, particularly from the provider community. In one breath, they'll say, I am in this for my patients, and my patients is what I really care about. And then in the next breath, they say, if you just pay me enough and pay me the right way, I will do the right thing for my patients. And this is really getting to your aligning incentives remarks. It's just incredibly frustrating. And is there a role for innovation in bridging that gap?
Yeah, so that's a tough and good question. Yeah, so I mean, one question is, what is enough? Frankly, I did work in France, and they have, physicians there, providers get paid considerably less than we get here. Of course, they don't pay tuition and things like that, but I think we maybe need to redefine enough. It's a interesting profession. I did some work on physician incomes. It's an interesting profession where we can say we're burned out and exhausted because we're working 50 hours a week with zero unemployment. We can go anywhere we want in the world to practice, and we make $500,000 bucks. And so I wonder what if enough is kind of misdefined by the profession. I think how do you get I think technology can facilitate better care and actually a broader care of patients. So instead of our system now, and I know it's changing with video conferencing and stuff like that, but historically I had to see you in my office to get paid, right? So I'm not going to answer your calls so much because it's just going to. So if we can change that, as lawyers get paid for phone calls, if we can change that, if we can provide technology where it's much more patient-centered. And available to the patient at when they want it, when they need it, for what they need it. If we can kind of substitute so people are operating at the top of their license, then I think the panel sizes could get bigger. The providers at every level could be more efficient, and they would get kind of enough and still be treating patients kind of very well. That's what I hope for, at least.
Next question.
Just a quick comment.
Yeah.
I'd like to say for a physician, primary care pediatrics can't be put in that same broad brush swath you talked about, going anywhere for 500 kids. I mean, I just need to make that.
That's, yeah.
Burnout on that front line is a whole different story than the surgical subspecialties.
That's fair enough, yep.
Did everyone hear that? Burnout is not one size fits all for all of the physicians.
Well, I think it's pretty. Burnout is like 40 to 60% in every profession, but I think incomes are different. Primary care physician incomes are considerably lower than they're more on the order of 300, and it's more like 700. 500 was an average.
Yeah. All right. One more question, right here, and you've got it. Oh, hold on 1 second. We need a mic.
Yes, I'm a physician as well. I think you've made some fantastic points. One thing I'd say is there's some low-hanging fruit that I think we could go after, which is outliers, and using data to find those. Yep. So I think most physicians are really trying to do the right thing, but there are some that are not. And we can't capture data right now to find those people. And whether it be education or disciplinary, or drop them from insurance plans, I think that needs to be something to be looked at. The other thing is that I think 10% of the patient population spends 70% of the healthcare dollars. So these high-risk patients, we're not capturing them well and we're not treating them well. If we did the multifactorial things that you were speaking of for that 10%, we'd save a tremendous amount of money. And then fraud as well, like you said, data will help capture that and save a lot of money too.
I think you're absolutely right. I mean, we say geographic variation at a higher level at Dartmouth. The more granular you go, you still find tremendous variation. And indeed, that's some of the systems we're setting up at Microsoft with some partners as ways to look at, variation within their system and across, if they have multiple places within their systems, to identify best practices to hopefully import those in kind of an IHI quality improvement kind of a way. So you raise all boats and get people kind of, practicing the best medicine they possibly can at the lowest cost. I think that's critical, yeah.
All right. This was fantastic. A really good way to kick off our 5 Points of Healthcare conference. Now, this year, what we are going to be doing is with each discussion up here, we would like to tie the panels together with a question that comes from the previous panel. So, Bill, the next up is we have our patient panel. What question would you pose to our patient panel?
Yeah, so my question for the patient panel, you let me think of this before, so is what do you want from healthcare?
Yeah.
And that's kind of broad because, maybe you want health, maybe you want, better access, maybe you want access whenever you want, but do you want healthcare? Healthcare is moving into social aspects of, to social determinants and thinking about that. What do you want from healthcare? You want us to do that kind of stuff? What do you want us to do?
Fantastic. All right, join me in thanking Bill.